All right, just testing this out. Perfect. So good morning, everyone. I'm Francis Lowe, one of the chief residents. I'm covering for Edward today. So welcome to Grand Rounds. Today we're excited to have Dr. Amber Afzal here. Dr. Afzal obtained her medical degree from Army Medical College in Rawalpindi, Pakistan. There she was her medical school classes valedictorian and was awarded the President of Pakistan's Gold Medal Award for Best Medical Student. After that, she went to the Cleveland Clinic for residency in internal medicine and then joined us here at WashU for a Hem-Onc fellowship. At the end of her fellowship, she obtained her Master of Science in Clinical Investigation. She's received several awards for her clinical and scientific work, including the Best Graduating Hem-Onc Fellow Award, Evan Sadler Memorial Travel Award, the ISTH Early Career Award, and the ASH CRTI Award. Her passion lies in the fields of thrombosis and hemostasis in liver disease and clonal hematopoiesis. Today, she'll tell us a fascinating story bridging hematology and hepatology. And please help me in welcoming Dr. Afzal to Grand Rounds.
Yeah, thank you for the generous introduction. So I have worked with many internal medicine residents in clinics, so I see some familiar faces in the audience, which is good. Let's start. I think I'll just stand here if you can hear me well. Yeah. Okay. So, I'm going to talk about the paradigm shift that happened in the understanding of hemostasis and liver disease over the past 2 decades, as I find it very interesting, and I hope you would too. I have no relevant financial disclosures for this talk. I'm currently one of the co-chairs of the ISTH subcommittee. ISTH is International Society of Thrombosis and Hemostasis. And this subcommittee is focused on hemostatic management of patients with liver disease. So some of my opinions may have been influenced by recent committee meetings. So why hemostasis and liver disease? Why did I choose this for my career in research and also to present to this august House of Physicians here? It's because we all know that liver disease is a common problem. It affects 4.5 million adults in the United States currently. And these people have a higher than average mortality. Cirrhosis is actually the 10th leading cause of death in the United States. And if you look at the causes of death, you would appreciate that bleeding with and without liver failure and thrombosis, particularly MIs and strokes, account for almost half of the deaths in this patient population. So it makes all the sense for hematologists and internists to learn about it, talk about it, and to join hands with gastroenterologists to improve the outcomes for these patients. I'll provide a little bit of background in terms of our understanding of hemostasis and liver disease here. And as you all know, before the 2000s, liver disease was thought to be an acquired bleeding disorder, and this was largely coming from the observations of a high incidence of variceal bleeding in these patients, where up to 1 in 3 patients with cirrhosis would suffer from a variceal bleed in their lifetime. And then bleeding would lead to extended hospital stays and higher mortality. So it was a common practice to avoid anticoagulation for these patients and to give them tons of blood products to prevent and treat bleeding, thinking that they have a hemostasis that is tipped towards bleeding at baseline. Now, these 2 scientists, Armando Tripardi from Italy and Ton Lisman from Netherlands, through their preclinical research, provided us new insights into the understanding of hemostasis and liver disease. They dispelled the old dogma that liver disease is a bleeding disorder and introduced the concept of rebalanced hemostasis in these patients through their research. So the important thing to understand here is that liver disease patients, particularly cirrhotic patients, of course, have a synthetic failure, but it is not only affecting the synthesis of procoagulant proteins, it is also affecting the synthesis of natural anticoagulants. And similarly, these patients have a cytokine storm that we tend to ignore, and this leads to increased production of the endothelium-derived coagulation factors, for example, von Willebrand factor and factor VIII. So this actually results in a compensation where thrombocytopenia that we see in these patients is counterbalanced by high von Willebrand activity, which is resulting in adhesion of platelets to the endothelium. Similarly, the prolonged prothrombin time or high INR that you see in these patients due to a deficiency of procoagulant proteins is balanced by low levels of natural anticoagulants like protein C, S, and antithrombin, and also by high factor VIII levels. And the proteins promoting and opposing clot lyses are also simultaneously affected. So this leads to a new state of hemostatic balance, which is more fragile and can easily tip towards bleeding by external factors like AKI or infections. But at baseline, in the compensated state, they have a balanced hemostasis with, albeit, a higher risk of thrombosis and a higher risk of bleeding than the population without cirrhosis. So I just would like to mention the unique phenotypes of hemostatic disorders and cirrhosis before proceeding any further in the talk to clarify a few concepts. So we note that the patients with cirrhosis, in addition to, of course, being at risk for thrombosis, DVT-PE, or cardioembolic stroke like any other patient, also have portal hypertension driven or dependent thrombosis, which manifests as splanchnic vein thrombosis. Similarly, they experience bleeding like in any location, like any other patient, but they also have portal hypertension-driven bleeding, which is commonly known as variceal bleeding. So when I talk about coagulation status and hemostatic balance, actually I'm referring to these phenotypes and not to the bleeding or thrombosis that is driven by portal hypertension, because that's an anatomical factor. It's not really reflecting the coagulation status of the blood. So as liver disease advances from, for example, Child-Pugh A cirrhosis to Child-Pugh C cirrhosis, naturally the portal hypertension increases, the portal pressures increase, so you have more of the portal hypertension-driven events like variceal bleeding and splanchnic vein thrombosis, their risk multiplies. What is happening to the coagulation status of the blood, though? So I think Tripathi did a very interesting study here, where he took the plasma from patients with cirrhosis, and he measured the ratios of natural procoagulants to natural anticoagulants. And he saw that as cirrhosis progresses from Child-Pugh A to Child-Pugh C cirrhosis, actually the ratio of procoagulants to anticoagulants increases, meaning the hypercoagulability of the blood increases. So as cirrhosis advances, the blood becomes more hypercoagulable. This actually got our VA outcomes research group very interested in understanding the hemostasis and in conducting clinical studies to kind of provide a proof of concept for the preclinical work that had been done in early 2000s by many scientists, including the two that I had shown earlier in the presentation. Our VA outcomes research group is chaired by Dr. Christensen and Filippo, and of course, we would have been able to do nothing without the help of Dr. Brian Gage. So we, in 2017, when I was still a fellow here, assembled a cohort of chronic liver disease patients in the Veterans Health Administration data, and we used an algorithm of ICD codes that had been validated in administrative data before, and selected 65,000 patients with chronic liver disease to conduct our research studies. So this has been an amazing journey, and the first study that we did was actually to investigate the effects of a prolonged INR on the risk of bleeding, non-variceal bleeding, in patients with cirrhosis, and we compared this to the effect of INR on bleeding in warfarin users who do not have that counterbalancing of high INR by decrease in anticoagulants. So we wanted to actually study the difference between INR effects on bleeding in patients with chronic liver disease, where the preclinical research proposes rebalanced hemostasis, and among warfarin users. And we used a multivariable analysis to get to our results. I would just like to mention here that at baseline, of course, most patients, 75% of the patients with chronic liver disease, had INR values less than 1.5. In warfarin users, of course, the INR is intended to be higher, so only 10% at different time points had lower INR values. So we also did a sensitivity analysis only for those patients who had INR values above 2 to allow a fair comparison, and the results were pretty much the same as the main analysis. So at baseline, the risk of non-variceal bleeding in patients with chronic liver disease, as you can see, it's 3% per year, was almost double the incidence of bleeding in warfarin users. So this kind of supports the fact that I mentioned earlier, that these patients have a rebalanced hemostasis, but a higher risk of bleeding and thrombosis than people without cirrhosis. And most of the hemorrhage in either groups actually happened in the gastrointestinal tract. So I would like you to pay attention to this figure here. Orange line represents warfarin users. The blue line represents actually the chronic liver disease patients. And you can see that as INR increases, the risk of bleeding in warfarin users increases. Between the INRs of 2 to 3, the risk of bleeding increases slightly. But as INR goes to the supratherapeutic range above 3, this risk of hemorrhage spikes. The same is not seen for patients with liver disease. They're starting off with a higher baseline risk of hemorrhage, but the hazards are not INR dependent and they're not really increasing as INR values increase, probably because of the counterbalancing by other factors in the blood that I initially mentioned. I would also like to mention that in our multivariable analyses, thrombocytopenia with platelet count less than 50,000 did not affect the risk of non-variceal bleeding in patients with liver disease, as you can see, whereas it increased the risk of bleeding threefolds in warfarin users, and hence we stop anticoagulants usually when the platelet count drops below 50 in those patients. And this also sort of clinically translates that preclinical research that thrombocytopenia in patients with cirrhosis is compensated for by increase in von Willebrand activity. So this was taken very well and, of course, provided, in a way, a proof of concept clinically for the preclinical research that had been done to show that high INR values do not really reflect the hemostatic status of the patients with cirrhosis. We then sought out to study the effects of prolonged INR on thrombosis, non-portal thrombosis in patients with cirrhosis. This was a single cohort study. This is yet to be published. And here, I would like you to just focus on actually this part of the multivariable analysis table. You can see that as INR is increasing from 1.5 to 3, the hazards ratio for non-portal thrombosis is also increasing from 1 to 2 to 3. And this is what Tripathi had shown in the preclinical study, that as actually Child-Pugh scores increase, probably as patients with cirrhosis become sicker, their disease becomes severe and INR increases, actually the hypercoagulability of the blood increases and the risk of thrombosis increases. So we should not really be combining the results from two studies ever, but because it was the same liver disease cohort, I took the liberty and did it just to kind of explain that in our cohort, we saw that the risk of hemorrhage in patients with chronic liver disease is not really dependent on the INR values. As INR values are increasing in patients with liver disease, they're becoming sicker, the risk of DVT-PE is actually increasing. So that leaves us with two questions. If INR, platelets, or for that matter, fibrinogen levels, they do not predict bleeding in patients with liver disease, what are the risk factors for non-variceal bleeding in these patients? And the second question you can ask me is, then what lab tests should we use to predict bleeding in a patient who's hospitalized with cirrhosis? So to answer the first question, we did this study where we actually studied the risk factors for non-variceal bleeding in our cohort of 15,000 patients with liver disease. We already know that portal hypertension-driven bleeding is driven by portal hypertension, but for non-variceal bleeding, we wanted to study the unique risk factors, if any, for patients with liver disease. And these patients were not on anticoagulant therapy, so that INR values reflect the liver disease instead of anticoagulation. So there was like a 4% per year risk of non-variceal bleeding in the absence of anticoagulation. Most of the bleeding events happened in the gastrointestinal tract, followed by the intracranial hemorrhage, which accounted for 10% of the non-variceal bleeds in these patients. And this is all just within a 12-month time period. And in addition to the risk factors for bleeding that you see in general population anyway, like alcohol abuse or risk of falls, the two that I would like to mention that are maybe a little more specific to the liver disease population is severity of liver disease, as measured by the components of MELD score or Child-Pugh classification, hypoalbuminemia, high bilirubin, lower GFR, higher INR. So the components of those scores that are used to calculate severity of liver disease, they correlated with increased risk of non-variceal bleeding. And the other interesting risk factor for bleeding in patients with liver disease is a recent infection within the past 30 days, including spontaneous bacterial peritonitis. And this is supported by preclinical research also. So it looks like infections tip the balance over towards bleeding in these patients, and then severity of liver disease must also be catered for when a patient is admitted when determining the risk of bleeding. The next question, The next question was what lab tests to use to predict bleeding if INR and platelets are not reflective of the risk of bleeding. So I must say there is really no perfect test at the moment commercially available that would perfectly capture the in vivo hemostasis that is happening in patients with liver disease. I would like to mention viscoelastic studies here that are available and very frequently used, like TEG scans for our patients to determine the need for plasma or platelet infusions. They have some advantages. For example, studies have shown that if you transfuse plasma or platelets based on the viscoelastic studies, you reduce the number of blood product transfusion compared to if you use the INR thresholds or the platelet thresholds for transfusions. So they would still at least reduce the unnecessary transfusion burden because the levels of some of the natural anticoagulants are accounted for by these studies. But there are many limitations also. The two most notable ones that I would like to mention are viscoelastic studies do not actually account for a decrease in protein C in the patients with cirrhosis because protein C activation requires thrombomodulin, which is generated by endothelium. So you're not really accounting for compensation of high INR by decrease in protein C, and hence you're still more likely to give plasma to a patient if you use viscoelastic studies to give it, than if you were able to capture the actual in vivo hemostasis. Similarly, the high von Willebrand activity is not captured by it because von Willebrand factor activation requires blood flow conditions, and those are not available in the viscoelastic scans. So you're still more likely to give platelets than you would if you were to accurately capture the in vivo hemostasis. So with those limitations, I would say, yeah, still better than INR and platelets, but not perfect. And most of the societies in the recent guidelines have not really recommended using these to give plasma or platelets, at least prophylactically. And thrombin generation assays, yes, are slightly better because thrombomodulin or another protein C activator is actually added to the assay. So you do account for protein C decrease in the patients. Again, von Willebrand factor activation is not accounted for. So they have some limitation. And also, I think, although they are better than most of the other assays that are available, they are not really commercially available in every institution and mostly reserved for research. So I don't think we can use it currently, at least, for determining the risk of bleeding in these patients. So with this, actually, I would move to the second half of the talk. I think we're doing OK on the time. So the second half of the talk is focused on the clinical scenarios that are relevant for internal medicine physicians. And this part of the talk would talk about how to deal with high INR or low platelets or abnormal conventional coagulation tests in hospitalized patients with cirrhosis, and especially like how to do prophylaxis and treatment for bleeding in these patients when they get hospitalized, and how to follow prophylaxis and treatment for thrombosis in these patients when they get hospitalized. So we'll review the limited data we have at the moment to answer these questions. And then I'll provide some society recommendations to provide some guidance in these areas when you encounter these situations in the hospitalized patients. So the first question that we can together try to answer is how to prevent bleeding, how to do prophylaxis for bleeding in a hospitalized patient with cirrhosis, for example, who is going to undergo a procedure or a surgery. I think this frequently comes up, that it's a hospitalized patient with cirrhosis, and they have like abnormal INRs, platelets, fibrinogen. How do you prevent bleeding if they are going for a procedure or surgery? What do you transfuse or not transfuse to improve the outcomes? So several studies actually, I don't know why I keep doing that, sorry. So several studies actually have been published to answer these questions. I chose the PROC bleed study for presentation today because this is actually a very large prospective international multi-center study, actually done by one of my friends at University of Virginia, Nick Intagliata, and his colleagues. And they collected data from more than 1,100 patients who were undergoing 3,000 procedures from several centers in the North and South America. And they showed that the risk of bleeding after procedures, which was only 3%, it was not determined or affected by the pre-procedure INR values, platelet counts, and the pre-procedure infusions that we give to these patients, like plasma to correct INR or platelets to correct platelets, did not reduce the risk of post-procedure bleeding. And all of these were statistically significant results, of course. And they showed that if anything predicts bleeding after procedures actually in these patients, it's higher BMI, severity of liver disease, like a higher MELD score, and then the nature of procedure, for example, intracranial surgery, vascular surgery, or an endoscopy requiring an intervention like ERCP with sphincterotomy. So that actually provided additional evidence in addition to several other smaller studies that had been published before showing no benefit to using blood product transfusions before procedures to correct numbers in these patients. And hence, you can see that in the latest Hematology Society recommendations, ISTH recommendations, and the recommendations from gastroenterology societies like American Association for Study of Liver Diseases and American Gastroenterology Association, they do not recommend even checking for INR, a number, platelet count, or fibrinogen in patients undergoing procedures. So they recommend not checking for these numbers and not giving them any blood products to correct these numbers before they undergo procedures. There's just one caveat here that I would like to mention. A preclinical study showed that thrombin generation is more robust when platelet count is above 50,000. So just by going by that preclinical study, ISTH recommends that in a patient undergoing a very high-risk surgery, like a neurosurgery or intraocular surgery, you can actually try to increase the platelets above 50,000, whether with the use of thrombopoietin receptor agonists like avatrombopag, if you have the time to schedule surgery, or in an emergency surgery, you can start a platelet transfusion an hour before the surgery to reach that goal. So that's maybe something you can still do, but for plasma and fibrinogen, there is no evidence that it would help to correct the numbers. Well, if you look at the current practice across the world, of course, it differs from the recommendations and the science that we talked about. All over the world, at least 1/3 of the hospitalized patients with cirrhosis are actually getting plasma. And in the United States, most of these patients, 77% of them, are actually getting it for prophylaxis of bleeding before procedures. Like, we are checking numbers and correcting them still. So there is a need for dissemination and implementation of the scientific knowledge here to reduce the unnecessary burden of blood product administration in these patients. Second clinical question that you can face is what to do if a patient with cirrhosis is actively bleeding and is having a non-variceal bleed. So, of course, there are not many large studies that compare blood product administration to no blood product administration in this scenario, because when somebody is actively bleeding, it is hard to kind of like randomize them to like no blood product administration. But the few smaller retrospective studies that we have show that a prolonged INR in patients with cirrhosis is hard to correct anyway with tons of plasma that you give these patients. The numbers don't correct. And then that doesn't really correlate with risk of rebleeding or mortality in these patients. So at least through smaller studies, we have learned that. So the recent society guidelines that I had shown, published after 2020, none of them really talk about blood product administration for treatment of bleeding, but older, more conservative guidelines that were published by American Gastroenterology Association in 2019 had recommended that we could consider keeping the platelet count above 50,000 and fibrinogen above 120 for somebody who's actively bleeding. So maybe that's something you can still do for somebody who's actively bleeding if you were to be very conservative. But even they recommended not checking INR, not giving plasma to correct INR, because that really has no value, even in the treatment of bleeding. So, so something to think about. Third situation, yeah, so now it's a patient with cirrhosis and he's hospitalized with high INRs, low platelets. Do you give them low molecular heparin or sub-Q heparin prophylaxis? Like, do they deserve prophylactic doses of anticoagulation to prevent DVT and PE? We note that these patients are at a higher risk of DVT, PE than other patients without cirrhosis. So here in reviewing the data, I would just like to talk about these two big meta-analyses that evaluated the role of thromboprophylaxis in patients with cirrhosis. One reported actually results using any anticoagulant for thromboprophylaxis. The other reported results with heparin. The conclusion from both of the meta-analyses was that the risk of bleeding really does not increase with prophylactic doses of anticoagulation in patients with cirrhosis. So it is very safe to give this. But it is actually interesting that it did not really decrease the risk of DVT and PE. It did not really have the efficacy that we were hoping for. It could be the lower event rate that led to it. But yeah, even if it was not really found to be efficacious in significantly reducing the rate of DVT and PE, at least we know that it did not increase the risk of bleeding. So coming to the recommendations, most societies, Hematology Society and the European Society of Liver Disease and the American College of Gastroenterology recommend thromboprophylaxis over no thromboprophylaxis for these patients with heparin or low molecular weight heparin. They who do, however, notice that if it is a critically ill patient or if somebody is actively bleeding, of course, you can withhold prophylaxis. But generally, it is OK to give these patients prophylaxis when they're hospitalized because it is safe. It doesn't really lead to increased risk of bleeding. And now, for those of you in the audience who want to join us for vascular liver disease research, these societies actually identified some areas of research here, which I noted down for you guys. So one of the interesting suggestions by ISTH is to include portal venous thrombosis as one of the outcomes for thromboprophylaxis and see if that thromboprophylaxis during hospitalization reduces that. And the other is, of course, for developing a VTE risk assessment tool, a tool that can predict the risk of DVT and PE in these patients, and then at least using thromboprophylaxis for those patients who are at a very high risk of developing DVT and PE. So in any way, the take-home message is yes for thromboprophylaxis unless somebody is critically ill or actively bleeding. If we look at the current practice, only half of the patients in the absence of active bleeding or other notable contraindications receive thromboprophylaxis with heparin or low molecular weight heparin when they get hospitalized in the United States. So yeah, the practice of thromboprophylaxis is kind of lagging behind still the recommendations and the research. So our final clinical question is, how do you treat thrombosis in these patients? When I say treat thrombosis, I mean using treatment doses of anticoagulant therapy. So is it OK for your patient with cirrhosis to receive treatment doses of anticoagulation for the management of splanchnic vein thrombosis, DVT-PE, or atrial fibrillation? Now, this is a nuanced question, and I will have to spend some time on answering this, and there are areas that we will identify in need of research at the end of this session. This is not as simple as the others, but let's see if we can make it easier. So the reason we kind of worry about use of treatment doses of anticoagulation is, of course, the risk of anticoagulant-related bleeding, because like we already saw, these patients are at a higher risk of bleeding than general population. So patients with chronic liver disease, when they develop atrial fibrillation, they have a 10% higher risk of stroke than people without cirrhosis. And when they get hospitalized, they have a 70% higher risk of DVT and PE than patients without cirrhosis. So the risk of thrombosis is significant. It is just about kind of counterbalancing that with the risk of anticoagulant-related bleeding. So what do you think is the annual risk of major bleeding with use of anticoagulants in patients with cirrhosis? When I say major bleeding, it is ISTH-defined major bleeding with 2 grams drop in hemoglobin requirement for 2 units of blood, or a bleeding at a critical site, like intracranial bleeding. So you can actually raise your hands, like when I go over the options, to see what you think. So what do you think is the annual risk of major bleeding if you use anticoagulants in this population? Is it 1 to 2%? Okay, 2 to 5%? And more than 10%? Yeah, so interesting. Yeah, so in patients without liver disease, it is 2 to 4%. But in patients with liver disease, we only have retrospective data because prospective trials wouldn't enroll them. And the risk of major bleeding is between 3 to 30%. Most of the studies reporting it to be above 10%. So I think whoever chose 2 or 3 was actually correct, but it is mostly in excess of 10%. So 1 in 10 patients are expected to have a major bleeding within 12 months after starting anticoagulant therapy. So this is a problem, and several studies show that liver disease increases the risk of bleeding, doubles it at least. And actually, we recently did a case crossover analysis in our cohort of veterans with liver disease and found that once they started anticoagulant therapy, their odds of bleeding doubled. So we are hopefully going to present it at ASH this year. And the same, of course, is supported by these risk prediction models for anticoagulant-related bleeding. Hemorrhages developed by Dr. Brian Gage here, Hasbled, and then Atria and others. They all support that liver disease itself is a risk factor for bleeding on anticoagulation. So it is a problem, and especially in patients with advanced cirrhosis like Child-Pugh B or C cirrhosis, some of these recent studies actually showed that 1 in 3 patients bled among those who had Child-Pugh B or C cirrhosis after starting anticoagulation within a year and had to discontinue anticoagulation. So it is not something that easy to start anticoagulation in these patients, considering these very high risks of anticoagulant-related bleeding. Just a word about like DOACs or direct oral anticoagulants versus the traditional anticoagulants, Lovenox or warfarin. We know that, of course, DOACs, because they're metabolized by liver to some extent, the clinical trials that actually led to their FDA approval did not really include patients with cirrhosis. So we really have no level 1 data. But going by retrospective studies, the risk of anticoagulant-related bleeding with DOACs varies from like 1 in 10 to like 1 in 2 patients, depending on the severity of liver disease, which I wouldn't say is largely too different from the use of warfarin. So I would say almost similar risk of bleeding, efficacy may be better. They're generally considered safe in Child-Pugh A, and selected patients with Child-Pugh B cirrhosis who have a lower perceived risk of bleeding. They are not recommended for Child-Pugh C cirrhosis because, of course, as liver disease gets worse, there's a higher risk of cumulative toxicity and bleeding. And recent data, a couple of studies actually support, both retrospective but large studies support that apixaban is safer than others if you were to choose a DOAC in patients with cirrhosis. So generally speaking, yes, the risk of bleeding is pretty significant, just like traditional anticoagulants. Just choose wisely. Yeah, this anticoagulant-related bleeding is always going to be a concern when you're starting a patient with cirrhosis on anticoagulation. So now we'll go through like those individual scenarios and see if we can come up with some guidance on how to treat them. So the first clinical scenario where you have to consider treatment doses of anticoagulant therapy is when a patient develops splanchnic vein thrombosis, which can happen in up to 25% of the patients with cirrhosis, depending on the stage of the liver disease. There's several meta-analyses, actually, that have been published since 2020 and in reputed journals. All of those meta-analyses actually deliver one message, that the use of anticoagulant therapy for splanchnic vein thrombosis, portal vein thrombosis in patients with cirrhosis reduces mortality. And it actually, of course, helps the recanalization of vasculature. When the vessels are recanalized, the portal pressures decrease, so the variceal bleeding actually decreases. So this is something supported by all of these meta-analyses. I only showed one here. But mortality decreases, variceal bleeding decreases, recanalization increases. But the risk of non-variceal bleeding, which is not portal hypertension, of course, goes up. So that is still a problem where the non-variceal bleeding risk doubles up, which includes intracranial bleeding. So if you look at this importal meta-analysis, I chose it because this was a very interesting meta-analysis recently published. Actually, it is a competing risk meta-analysis, and it showed that anticoagulant therapy compared to no treatment would actually reduce mortality. And this mortality was actually independent of the vessel recanalization. Like, even if the vessels did not open up, like, the mortality decreased with use of anticoagulant therapy, suggesting some off-target effects, which some of my basic science colleagues, like lab researchers across the country, for example, one in Michigan State University, are investigating as to what those off-target effects could be that are actually improving survival, regardless of the vasculature recanalization. But coming back to the topic, it looks like generally it reduces mortality. Now, how I would like to mention this caveat that meta-analyses are done with retrospective analyses, right? So there could have been some selection bias where only the patients with lower perceived risk of bleeding actually received anticoagulant therapy. So kind of we have to keep that in mind. So most of the societies, Hematology Society and Gastroenterology societies, recommend using anticoagulant therapy for acute splanchnic vein thrombosis and for symptomatic splanchnic vein thrombosis, for like, for example, SMV thrombosis that is causing bowel ischemia. So for acute or symptomatic clots, yes, do anticoagulate. For chronic thrombosis, because the damage has been done usually, like if portal hypertension had to develop, it has developed. For the chronic clots, like for example, some of the portal veins have now, you will read on the imaging that there is cavernous transformation of the portal veins. So some of them have developed collaterals already. So whatever damage had to happen has happened. So in those cases, the expected benefit from anticoagulation is minimal. So in your very high risk of bleeding patients, you can choose not to anticoagulate for some of these scenarios. For example, the American Gastroenterology Association said, even if the patients put a very high value on the bleeding risk conferred by anticoagulation, then consider not doing it if the expected benefit is minimal. So we have to consider that the splanchnic vein thrombosis or portal vein thrombosis, we are treating it to just improve long-term outcomes, which is that the clot should not progress to cause more portal hypertension, more variceal bleeding. So if it is a chronic clot and the risk of progression of the clot is minimal, and if the vessels have collateralized, and your patient is at a very high risk of bleeding, has Child-Pugh C cirrhosis or like advanced Child-Pugh B cirrhosis, then you may want to just not do anticoagulation, because here the expected benefit you're going to reap from anticoagulant therapy is minimal. So I hope this was clear, and then we can, this is actually should be a talk in it by itself, but yeah, in the interest of time, we will move on to the next scenario, which is using treatment doses of anticoagulation for DVT-PE. So I think it's a no-brainer that, of course, if somebody's presenting with a significant pulmonary embolism or a proximal DVT with higher expected morbidity and mortality, treat them. So the studies are not ever going to find that clinical equipoise not to treat them and then study the outcome. So treat them if they're not actively bleeding. But for certain scenarios where the predicted mortality is lower, for example, distal DVT, and you can do serial scans, or like an isolated subsegmental PE, whether you should always anticoagulate these patients given their high risk of anticoagulant-related bleeding is still a question and needs to be answered by more research. Similarly, yes, you're treating the acute event, but do you really keep them on anticoagulation forever if their risk of bleeding is very high just to prevent more events? So that is also a question that still needs to be answered. So there are unanswered questions for sure in this area, but largely speaking, yes, for a significant DVT and PE with higher predicted mortality in the acute setting, yes, anticoagulate, unless the patient is having a major bleed at that time. We actually reviewed data. I would say we actually highlighted the paucity of data that exists for using DOACs to treat DVT and PE in patients with cirrhosis, and it was published in ASTRA. Just put it here for you guys to review, but there's very limited literature that actually provides guidance in terms of using DOACs to treat DVT and PE in these patients, because yes, the reported risk of bleeding is very high, and a lot needs to be done to actually mitigate that risk. So it's a third scenario, which is using treatment doses of anticoagulant therapy for patients with atrial fibrillation. So I would say most of the meta-analyses actually support, of course, the use of anticoagulation for people with higher Child-2 scores, and especially a higher Child-2 score above 2. And that reduced the incidence of stroke, but also reduced the incidence of actually hemorrhagic stroke in these patients once they developed atrial fibrillation. So generally, yes, the recommendation is to treat atrial fibrillation with higher Child-2 score. But I would like to mention this study here that was published in 2015 and actually kind of looked at net anticoagulant benefit that a patient with cirrhosis who develops AFib is deriving from anticoagulation. And this was interesting. They only used warfarin in this study, but they saw that patients with Child-Pugh cirrhosis, because they have a lower risk of bleeding, in them, anticoagulation actually had a net benefit for these patients. Whereas for Child-Pugh B or C cirrhosis, because the risk of major bleeding was significant after starting anticoagulant, it actually overwhelmed the stroke reduction benefit. So there was no net benefit these patients derived from initiation of anticoagulation. So something to think about. I thought was interesting, and we should do that with DOACs too, now that we know that studies have shown that DOACs are actually safer than warfarin in terms of bleeding for treatment of AFib in these patients, at least. So studies support the use of DOACs over warfarin for atrial fibrillation and cirrhosis. I think a similar analysis should be done where we could see if even in patients with advanced cirrhosis with a very high risk of anticoagulant-related major bleeding, it makes sense to treat every patient with AFib and Child-2 score above 2. So coming to the recommendations or society recommendations, the American Heart Association published guidelines last year. And they generally recommend anticoagulant therapy with DOACs for patients with Child-Pugh A and B cirrhosis. They, however, note that if you think the patient is at a clinically significant risk of bleeding, you may omit it. So they kind of leave it up to your judgment in the end, even for these patients. And similarly, American Gastroenterology Association generally recommends it. But they say if it is a patient with very advanced cirrhosis, or if a patient puts a very high value on the risk of major bleeding as compared to the stroke reduction benefit, then you may omit it. So there's still some physician discretion involved here, even among patients with Child-Pugh A and B cirrhosis in terms of choosing patients for anticoagulation. But generally speaking, yes, do it, and do it with DOACs if the patient has Child-Pugh A or B cirrhosis. Looking at the current practice of use of treatment doses of anticoagulant therapy for patients with cirrhosis across the country, we see that actually it is lagging behind again, just like thromboprophylaxis. It is lagging behind the recommendations and the science. Using our veterans cohort, we saw that only a quarter of the patients with AFib and Child-2 score above 2 are actually receiving an anticoagulant prescription, and only half of the patients with DVT and PE are receiving a prescription. Similarly, using the market scan data, a study was recently published, which actually market scan accounts for most of the other insurances across the country. And this study also showed that only half of the patients with Child-2 score above 2 are receiving anticoagulant prescriptions. So there is some hesitance there in prescribing treatment doses of anticoagulation for patients with cirrhosis for their perceived risk of bleeding, which you can see in the current practice. So how do we change that? How do we improve the current management, improve upon the current management, the current standards of care of practice in terms of treating splanchnic vein thrombosis, DVT, PE, and atrial fibrillation in patients with cirrhosis? I think what we need to do is to just ensure that every patient with cirrhosis who's walking up to your clinic or who's getting hospitalized, for them, you ensure that if you're starting anticoagulation, the expected benefit of anticoagulant therapy outweighs the potential risk of major bleeding and bleeding-related deaths. So this is, if we were somehow able to ensure that, then we could provide that net anticoagulant benefit to each patient with cirrhosis walking up to us, and we could actually encourage physicians to prescribe anticoagulation more often than they're currently doing. For this, it looks like we need to exactly know what the potential risk of anticoagulant-related bleeding is in a patient with cirrhosis. So we must be able to accurately stratify patients for the risk of anticoagulant-related bleeding. If we are able to do it, and if we are able to identify the patients who are at a very high risk of anticoagulant-related bleeding, then we can do a few things before we start anticoagulation. One, of course, we can offer alternatives, like, for example, for management of atrial fibrillation, you can use a Watchman device, like left atrial appendage occlusion devices, instead of long-term anticoagulation if the perceived risk of bleeding is very high. So you can offer alternatives. The second is you can actually modify the risk of bleeding. For example, you can do an endoscopy and band their varices before you start anticoagulation. You can start them on a beta blocker or a PPI to reduce the incidence of GI bleeding. You can optimize their kidney function, treat their infection before you start anticoagulation therapy. So if you are able to identify the very high risk of bleeding patients, you can either offer alternatives or modify the risk of bleeding before initiation of anticoagulation. That is more likely to optimize the outcomes, and then eventually in your patients that you select for anticoagulant therapy, you will be maximizing the net anticoagulant benefit. So that, if you do a research on these lines, then that would hopefully encourage physicians to prescribe anticoagulation when it is going to provide net anticoagulant benefit, and it is hopefully going to help standardize practice across the country. So our VA group of research also got interested in this area, and we thought we should see if we really have a tool that accurately estimates the risk of anticoagulant-related bleeding in these patients so that it can be used by physicians to estimate the risk of bleeding before starting treatment doses of anticoagulation, and and if there is a tool that can actually basically help us personalize care for the patient with cirrhosis who's walking up to your clinic. So we evaluated the performance of the existing risk prediction models for anticoagulant-related bleeding in our cohort of veterans with liver disease. So we had 4,000 plus patients with cirrhosis who were on anticoagulation. So we tested the performance of these models in this cohort. This table here actually shows the baseline characteristics of the patients who bled and did not bleed after starting anticoagulant therapy. The two most notable differences in the baseline characteristics were a bleeding history and the MELD score. So those who had bled in the year prior to starting anticoagulation were more likely to bleed after starting anticoagulation. And then those who had a higher MELD score, of course, were more likely to have bleeding after they started anticoagulation. And this next table here actually shows the performance of these risk prediction models for anticoagulant-related bleeding, Hasted, hemorrhages, VTE, bleed, orbit, and there were others. I only chose these in patients with liver disease to see if they can predict bleeding. So I would like you to focus on this area here, which presents the C statistic, or the discriminative ability of these models for patients with liver disease. This C statistic tells us if a model is able to discriminate between high-risk patients and low-risk patients. And you can see that for all of these models, it is close to 0.5, which, and the C statistic values can range between 0.5 to 1. And 0.5 is only as good as flipping a coin or a random chance, a random guess in estimating the risk of bleeding. And it looks like, yes, these models did not really perform too much better than a random guess in selecting high-risk patients. So it looks like with the available risk prediction models for anticoagulant-related bleeding, it may not be able to predict the risk of bleeding, select the high risk of bleeding patients within the population with cirrhosis. And it is likely because we discussed they have a unique hemostasis, INR and platelets don't predict their bleeding risk, and they have unique phenotypes of bleeding. So this led us to think that we should develop a risk prediction model which is specific to patients with cirrhosis. So this is going to be our next step in research that we are working on currently, that we're going to develop a risk prediction model which is specific to this population using a cohort of veterans with chronic liver disease and atrial fibrillation that we have already identified. This cohort is using anticoagulant therapy, and we will develop a model using this cohort and then validate that model using the BJC data in a cohort that we have already identified. And hopefully, if we come up with a model with a good performance, a model that can accurately discriminate between patients in terms of their risk of bleeding, then we will use decision analyses to study the net benefit that that the patients in each bleed risk stratum are deriving from anticoagulant therapy. For example, a patient with very high risk of bleeding, with CHA2DS2 VAS score of 2, may not derive a net benefit from use of anticoagulation, treatment doses of anticoagulation for AFib, and then you may want to consider alternatives. So to provide guidance that leads us to individualized approach to starting anticoagulation, personalized medicine, we hope that this research will help the physicians and the physician scientists across the country. And this is what we're currently working on. I will sum up the talk here and just go over these few take-home messages. If you don't remember anything else from this talk, just remember that patients with cirrhosis have a rebalanced hemostasis despite their low platelets, despite their high INR that you're seeing on labs all the time. Please do not use fresh frozen plasma, fibrinogen concentrates, or platelets to prevent bleeding before procedures. Don't even check these numbers is what the societies recommend. And evidence does not support the use of plasma to even treat active bleeding. You may want to still consider giving them fibrinogen concentrates or platelets. There's no evidence there, but at least one society back in the day in 2019 had recommended that. Anticoagulant prophylaxis, sub-Q heparin or low molecular weight heparin, that's still something you can do for all your hospitalized patients. It doesn't at least increase the risk of bleeding. When it comes to anticoagulant treatment of thrombotic conditions, yes, as we talked about it, it needs to be fine-tuned based on an individual's risk of anticoagulant-related bleeding. That still needs some work, so we should be able to estimate it and then fine-tune the management of these conditions. So, yeah, researching the hemostasis and thrombosis in liver disease, I felt like what Rumi must have felt when he said, the closer I get, the more I see how far I am. So there's a lot to be done in this field. A lot of research is needed. And if any of you wants to join hands with us, please join the group. You're welcome to. There's a lot that still needs to be done. But I hope with the help of physicians and physician scientists like all of you, we will be able to get somewhere. With this, of course, I would like to thank Dr. Brian Gage for being the most amazing mentor I could have since my fellowship. And I would like to thank the VA Cancer Outcomes Research Group chaired by Dr. Kristen Sanfilippo, who has provided invaluable support in conducting all of our research studies that I mentioned in this talk. Dr. Kevin Korenblatt, a gastroenterologist at WashU, who gave us some very useful feedback on designing the studies for this patient population. And last but not the least, ISTH, that helped me connect with the gurus in the field like Ton Lisman. And now we are working on international multi-center studies together, which is amazing. Yeah, so thank you. And I'm open for any questions that you may have. Yes.
Add variceal bleeding into those trials, like how much workforce is it?
Yeah, so for the initial studies that we had done in the first half of the talk, like I talked about the rebalanced hemostasis and the coagulation status of the blood, so those were focused on non-variceal bleeding. But when we are talking about anticoagulant-related bleeding, you know, the numbers that I reported from 1 in 10 patients to even half of the patients bleed on anticoagulation, then we are actually looking at both the risk of variceal and non-variceal bleeding. So that's a good question. And actually, it's only splanchnic vein thrombosis where you can expect the variceal bleeding not to go high or to actually improve with anticoagulation because you're opening up the portal circulation and reducing the pressures in variceal bleeding. But when you use treatment doses of anticoagulation for atrial fibrillation or DVT-PE, yes, you increase the risk of both variceal and non-variceal bleeding, and that is what the limited data that we have at the moment suggests. Yeah. Yes. Yeah, that is actually a great question. So I think we thought that either hepatic encephalopathy was being coded as dementia, which is possible when you use ICD codes, and that just is telling you that the patient has advanced liver disease. Or yes, it does contribute to the risk of falls, and that is how these patients are getting more bleeds. But yeah, we did not really apply frailty score, and that's a good idea. Yeah. Yes. Yeah, that is such a struggle. Tell me about it. Yeah, we get these consults all the time, and yeah, no matter what we write, of course, like they're not gonna take the patient to the surgery or the OR and do it. I would say yes, there's that caveat that, yeah, you can still use platelets or hang platelets during the procedure, but there's really no value to plasma. And it has been even shown, there were 2 randomized trials. They had few patients, but there were 2 randomized trials in patients with cirrhosis, just looking at plasma versus no plasma to correct INR before procedures, and nothing really panned out like in terms of any significance. Actually, in one of the studies, because you were giving tons of plasma, you were increasing portal pressures, the volume and the portal pressures, you increased the variceal bleeding by giving plasma. So yeah, maybe smart dissemination and implementation scientists can help us there, come up with something that helps implement yeah, this scientific knowledge we talked about. Yes. Yeah, there was a preclinical study that showed that a bacterial infection had heparinase-like activity, and it actually led to coagulopathy. There was another suggesting changes from bacterial infection actually in the endothelium that actually promoted more bleeding and delayed healing. So there are those preclinical studies that I saw. But then in terms of clinical research, yeah, I mean, like our study showed it, and then a couple of other small retrospective studies showed that a recent infection tipped over these patients towards bleeding. So yeah, so probably there are changes in endothelium that lead to it.
Regarding kind of thromboprophylaxis in patients, are there any populations at all that you would not consider thromboprophylaxis other than like active or very recent bleeding? Classically, we use low platelet count as a marker, but that's not a great marker of kind of bleeding risk, it seems like. So are there any indications where
Yeah.
you have a really advanced
I think that's a great question. Yeah, there's definitely a need for being able to determine the risk of anticoagulant-related bleeding in any patient, just like we talked about. So I think if we develop such a model, it will help choosing thromboprophylaxis also. At the moment, the societies say, yes, any child PUC cirrhosis patients, critically ill patient, actively bleeding patient, yes, withhold pharmacological thromboprophylaxis. But yes, there is a need for more research to identify additional patients with advanced cirrhosis, who could maybe have a higher risk of bleeding with prophylactic anticoagulation. Generally speaking, the 2 meta-analyses that I showed, and they included several studies, they were big meta-analyses, they showed that the prophylactic doses of anticoagulation somehow, like they did not really, in any of the studies, increased the risk of non-variceal bleeding or variceal bleeding significantly. So they're thought to be safer, and hence, if somebody's not actively bleeding or a child PUC critically ill patient, I would still do thromboprophylaxis. Yeah. Oh, thank you.